So one huge outcome of the use of antimicrobials is the development of resistance to medications. Microorganisms begin to tolerate an amount of the drug that would ordinarily be inhibitory. This is due to the fact that microorganisms are constantly undergoing mutations, especially viruses, and they're very genetically versatile. So they are constantly adapting, which is good for them, but a problem for us. So resistance to penicillin actually developed in some bacteria as early as 1940. This is not a new problem. In the 80s and 90s, scientists began to observe treatment failures on a large scale. Microbes become newly resistant to a drug after one of the following things occur. Spontaneous mutation in a critical chromosome gene, acquiring or obtaining a new gene or set of genes via that horizontal transfer that we looked at from another species, okay? And so that's problematic for us. So we already stated that this occurs due to spontaneous random mutation, and that slight changes. What happens is gives natural selection something to act on. So you can see here in the picture here, a few bacteria may develop a mutation, okay, that allows them to be drug resistant. There's only one, two. So what happens? Well, we take our medications. Well, we go and we kill off all of those that aren't resistant, and so what's left? The resistant guys. And so then the ones that are resistant will be able to replicate, all right? And then once they replicate and they are spread, they can actually give other bacteria those genes with transfer that allow them to be resistant. So this is a problem, and this is really something to take very seriously in our, not just our country, but worldwide today. So bacteria can actually kind of go to sleep when they're exposed, not like literally asleep, but that's just a way of explaining it. When they're exposed to antibiotics, they actually slow their metabolism to actually protect themselves and kind of avoid being harmed by them. Then they're able to rev back up their metabolism whenever the dose decreases. So these guys are pretty handy. This is what we call persisters, okay? And this is something that biofilms actually do. All right, so obtaining resistance to horizontal gene transfer. Resistance through that horizontal transfer begins with the plasmids and resistance factors that are obtained through conjugation, transformation, or transduction, okay? We also have transposons, which are drug-resistant sequences that can be copied and pasted into one plasmid from another to another from a chromosome to another chromosome. Okay, and these are then copied and passed on. All right, so this resistance development and long-term consequences. Any population, a large population of microbes, can have a few cells with a little bit of drug resistance. As long as the drug is not present in the habitat, then those genes aren't going to be expressed. If it is exposed, if it's in the habitat, then the drug resistance population will have that selective advantage, meaning we kill out the ones that don't have it, they will survive and go on to reproduce, okay? And so their offspring will inherit that resistance, and they will continue to evolve and become the dominant species, which is what we looked at in that picture. So in 2013, the CDC outlined a potentially catastrophic antibiotic resistance situation. So we're now in we're maybe entering a post-antibiotic era where some infections will be untreatable. So new and effective treatments, they've been really kind of slow to come to market. Antibiotics are not economically lucrative, meaning they don't make people a ton of money, so there's not a good initiative to make them. And they're very timely and consuming to develop. So the CDC has categorized resistant bacteria into 3 groups or hazard levels: concerning, serious, and urgent. So in the US, 2 million people a year are infected with resistant bacteria, okay? So we have our urgent threats. This is like C. diff, all right? Neisseria gonorrhea or Enterobacteria. Serious threats, we have things like Acinetobacter, Campylobacter, and even Candida that are resistant to fluconazole. And the really concerning ones are, we've had MRSA, right? Methicillin-resistant Staphylococcus aureus. We're pretty familiar, generally, most people are, with the antibiotic-resistant staph. That's MRSA, methicillin-resistant Staphylococcus aureus. Methicillin is what's called a last resort antibiotic, meaning that's one of the strongest ones we have, and when we have nothing else, we try that. But we are also now having problems with the other last resort antibiotic, which is vancomycin. So we're now seeing Versa, which is vancomycin resistant Staphylococcus aureus. And we're also having issues with erythromycin and clindamycin resistance. So this is a serious issue, and why they often try to avoid prescribing antibiotics when they are not needed. We do have some new things on the horizon. We have RNA interference strategies that can be used to shut down the metabolism of pathogens. We can use what we call defense peptides. These are proteins that are actually part of our innate immune system, which is the immune system that we are born with. These defensins have antimicrobial attributes that do things like disrupt the cell membrane, destroy the cell, or inhibit the microbes from fusing into cells. And so these are really promising new approaches on the horizon. CRISPR is also another really good approach. This uses palindromes, kind of similar to restriction enzymes. And so this is another area that we have found in bacteria that can actually cause a specific cut in a gene. And this is going to be able to help us to assist in overcoming antibiotic resistance. We could actually destroy and cut out those genes that cause resistance, okay? We have what we call non-cultivable bacteria. This is a new method to grow antibiotics called tioxobactin, and that's going to inhibit cell wall synthesis in a little bit of a different way. And so these are really some promising areas. The next best method here is using bacteriophages. Remember, those are viruses that infect bacteria. So if they can spread antibiotic resistance from one bacteria to another, why can we not use them to fight that, okay? So the enemy of my enemy is my friend, right? Bacteriophages infect them, so why not use them to destroy them? Okay, and so we actually are using some of these. They are approved in some areas of the world, not necessarily here yet, but they are used against some biofilms where we have Pseudomonas. Pseudomonas is particularly hard to destroy. They're actually putting them in wound dressings, and they are. One of the advantages is they have a narrow specificity, so they will only attack one particular thing, which is good. Prebiotics and probiotics are something most of us are familiar with. These are preparations of live microorganisms used to improve normal intestinal biota. These can replace microbes that are lost during antimicrobial therapy or augment what is already there, and that's a probiotic. Okay, for example, consuming yogurt to help grow beneficial bacteria. All right, so lots of good uses for prebiotics and probiotics. Prebiotics are going to be nutrients that encourage growth of beneficial microbes, okay? This is going to be sugars such as fructose, yogurt for the beneficial that are beneficial for microbes. That's going to encourage the growth of bifidobacterium, all right, and discourage others from growing because due to things like just general competition. Okay, now fecal transplants. This is kind of a touchy issue. They have had some issues here with passing on antibiotic resistance. All right, but we do use these to treat things like C. diff, which is particularly nasty intestinal bacteria that is a big problem in things like nursing homes. And so what they actually do is transfer species from a healthy patient to a patient that needs a little extra help, and helps them to recolonize the normal microbiota. But like I said, the problem that we have seen with this is we are also passing along some antibiotic resistance. So it was really something people were really excited about for a while, then it's kind of gone back down, and we'll have to see how that plays out. All right, time for another practice question here. An RN in a family medicine office provides education for ill patients being prescribed antibiotic therapy. Consumption of yogurt is encouraged as it is a prebiotic, natural antimicrobial, superbiotic, or probiotic, right? And it says that it contains live microorganisms that improve intestinal biota. So pause and come up with your answer. So really here you should only have two options. You should either be wanting to choose prebiotic or probiotic. So which one is it? It is D probiotic because it has the live microorganisms already in it. Prebiotic means that it is going to, remember, enhance the area, so to speak, for microbes to grow, the ones that we want to grow. So major side effects of drugs can fall into three categories, all right? We have direct damage by toxicity, allergic reactions, and then, of course, disruption of normal microbiota. Okay, so we need to be careful and manage this very well. The drug is going to be administered to the host, even though the target is a microbe. And the effect, of course, has got to be considered. And those three categories are what we want to look at. About 5% of people are going to actually have an adverse reaction of these three types that I just mentioned here, okay? So drug toxicity is an issue and something we need to be mindful of. They can adversely affect all of these organs here. If it is hepatotoxic, hepato usually refers to or does refer to the liver. Nephro refers to kidneys, so nephrotoxic, the GI tract, all right, often due to those killing off the beneficial bacteria or irritating it. Cardiovascular system, so hemo is going to be cardiovascular or blood. Neuro, of course, refers to the nervous system. Respiratory toxicity, skin or bones and teeth. All right, so what is an allergy? What is anaphylaxis? All right, drugs can act as an antigen that actually stimulate an allergic response. This can be provoked by the intact molecule or by substances that develop from the body's metabolic alteration of the drug. Allergies have been reported for every major type of drug, but an allergy to penicillin is most common. Sensitization occurs during the first contact with the drug. All right. Second exposure then can often lead to hives, respiratory inflammation, or anaphylaxis. Now, anaphylaxis does not necessarily just mean not being able to breathe, okay? That is systemic anaphylaxis, all right? Anaphylaxis is any reaction. If I get stung by a wasp and I have an allergic reaction and I swell up greatly, but I can still breathe fine, it is still anaphylaxis, okay? It's just not systemic, so be careful with that terminology. Let me quickly add for the last slide, anaphylactic shock is what I mean when I say systemic. That is when you get the swelling where you cannot breathe. And that is what we typically think of when we hear the word anaphylaxis, okay? Okay, so broad spectrum antimicrobials destroy microbes in many areas, all right? So if therapy destroys the beneficial species, other microbes can actually overgrow and overpopulate and become opportunistic infections. This is what happens whenever, for instance, we're taking antibiotics and we wind up with a yeast infection. It is an overgrowth. It has become opportunistic, okay? And then we can have what we call a super infection, and that's when microbes that were once small enough in number overgrow, and because they don't have any competition. All right, so if I have my normal microbiota and I have 2 or 3 different types, and they're living together, and there's only so much food, they have only so many numbers of population they can have, or they don't have enough food to eat. Well, if you kill off one species, suddenly there's a whole lot more food. Okay, so there's no more competition. And so that species suddenly has all the food that it wants, and it can just grow and grow and grow and grow. Okay, now that's a simplification, but that's basically what we're talking about here. All right, so here's some examples of those super infections. Okay, yeast infections I already mentioned of the vaginal tract, C. diff. Causing colitis following antibiotic treatment. Okay, that is a huge predisposition for getting Clostridium difficile is by being on antibiotics beforehand. All right, it can be a super infection, and that is a pretty pretty nasty, uncomfortable one to have as well. Well, and Candida albicans is, but it's not near as dangerous as C. diff. That can actually be life-threatening. So let's see. I guess those are the only two here that we were going to talk about. That antibiotic-associated colitis, which is going to cause diarrhea, a lot of abdominal pain, and it actually invades and likes to sit in the intestinal lining, the C. diff, and it can kind of go away for a while and then come back. All right, so particularly problematic. So this is just another illustration of those super infections. So here in A, over here in A, you have a primary infection of the throat, is treated with an oral antibiotic, okay? And so here is a drug-resistant pathogen, all right? So we kill off all the normal microbiota, all right? So here in B, the primary infection is cured, but the drug-resistant pathogens have survived and create an intestinal superinfection. And so now we have another problem. We've traded one for another, unfortunately. So this is a dilemma that we are definitely seeing in healthcare. Growing awareness has led to a reduction of the practice of using antimicrobials for a cure-all for things like the common cold. The common cold is often caused actually by viruses, all right, like COVID. Coronaviruses are one of the main causes of the common cold. This just happens to be a particularly nasty variant that we've had lately. And so we used to just throw antibiotics at everything. And we have now come to the understanding that that shotgun-based approach is not a good thing. Okay. Still, patients often will push for antibiotics when they do not need them, but we have to, as professionals, not fall under not fall into that pressure. Okay, so it is very important as a health professional to be aware of not only the proper use of antimicrobials, but also their limitations, and to be able to educate patients to the proper use of such so that we can reduce the spread of antibiotic resistance and resistance to other medications as well.